All right, great. Well, we wanted to welcome and thank everyone for joining us today at today's Stroke ISIG webinar. This webinar is part of a series put on by the ACRM Stroke ISIG to help bring needed information to rehabilitation clinicians and researchers. We will share a link for the Stroke ISIG webpage in the chat, and you can look here for some more information about the ACRM and the Stroke ISIG using that link, or you can contact the Stroke ISIG chair, Maria Cecilia Alapisan, using the contact information that's provided here. My name is Mara Steinberg-Lowe, and I am one of the co-chairs of the ACRM Stroke ISIG Aphasia and Other Communication Disorders Task Force. Amy Vogelini is the other co-chair and is also on the call today. And we are so delighted to present this webinar today, titled The Power of Communication Partner Training in Rehabilitation, Evidence, Models, and the Impact on Interdisciplinary Clinical Practice and the Patient Experience. Our speakers today are Juliana C. Valentin, Lindsay Escott, and Katie Hatula, and the session will be moderated by Elissa Larkin. Elissa Larkin is a research speech-language pathologist at the Center for Aphasia Research and Treatment and a bioethicist in the Donnelly Ethics Program at the Shirley Ryan Ability Lab. She holds a master's in communication disorders, bilingual Spanish from Arizona State University, and a national certification as a healthcare ethics consultant. Her work focuses on ethical frameworks in rehabilitation, interprofessional communication, and care partner training. She leads the year-long Communication Champions program and received the 2023 ASHA Louis M. DiCarlo Award for her work in communication access and advocacy. Juliana Valentin is a senior physical therapist at the Shirley Ryan Ability Lab in Day Rehab. She earned her DPT from Boston University and completed a neurologic physical therapy residency at Northwestern University and Shirley Ryan Ability Lab. Her clinical interests include stroke and brain injury recovery, balance and dual task training, and supporting patients with aphasia. Juliana is trained in communication strategies for people with cognitive communication impairments and serves as a communication champion at her site. Lindsay Escott has over 18 years of experience in neurological and medical rehabilitation across Australia, Canada, and the US. She holds post-professional master's and doctorate degrees in occupational therapy from Mount Mary University, with expertise in cognitive rehabilitation and care partner collaboration. Since joining Shirley Ryan Ability Lab in 2021, Lindsay works in the Think and Speak Lab and integrates supportive communication strategies into therapy, advocating for care partner involvement to enhance patient participation in meaningful activities. Katie Hatula earned a BS in teaching in 2015 and an MS in curriculum and instruction in 2018 from Western Illinois University. She has taught at both elementary and high school levels. In 2023, Katie experienced a massive stroke, resulting in right-sided paralysis and speech loss. After 5 weeks of inpatient rehab at Shirley Ryan Ability Lab, she returned to teaching in August 2023 and continues independent therapy at home. Before we get started, I wanted to advise that this meeting is being recorded. Please make sure you mute your mic and turn off your camera during the presentation. We will have 15 minutes for Q&A at the end of the webinar. If you have any questions, you can submit them via the chat. So without further ado, I'm going to turn it over to Elissa and her team.
Thank you so much, Mara, for that wonderful introduction. We are very honored to have this opportunity to present today on this topic, the power of communication partner training in rehabilitation. As Mara said, I am a research speech-language pathologist and bioethicist at Shirley Ryan Ability Lab in Chicago, and I'm really grateful to be presenting alongside my colleagues Juliana Valentin, Lindsay Escott, and Katie Hatula. We'll each say a little bit more about our backgrounds, particularly during the panel discussion. We have very minimal disclosures here to share. And in terms of our agenda, there are really two main parts. I'm going to start things off by talking about what communication partner training is and sharing the evidence that supports it, and offer an example of an interdisciplinary communication partner training program that we run here in our hospital, and offer some reflections as the facilitator of that program. And then we'll hear from our panelists who will share their reflections as clinicians who have participated in our communication partner training program. And Katie colleague's perspective as a former patient in our hospital. And then we are very excited and hope to have plenty of time for discussion and questions at the end. We have 3 main learning outcomes. I'm going to tackle the first 2 in the first half. So we'll define what communication partner training is and really think about it within the context of interdisciplinary clinical education, and also summarize what the current best practice evidence says about CPT, and what some considerations are that we want to highlight about implementing CPT in rehabilitation settings. And then our panelists will describe examples of impact of communication partner training on interdisciplinary clinical practice and patient experience. So before I talk about what communication partner training is, I always like to start out with why it is so important. The United Nations Convention on the Rights of the Person with Disabilities stated that providing communication supports to those who require them is a human right. And this aligns with our national guidelines in the US that are codified within the Americans with Disabilities Act, as well as recommendations from one of our primary accrediting organizations for healthcare organizations, the Joint Commission, who stated that effective communication is not only every patient's right, it's also an essential component of ensuring that we are providing high quality care and ensuring our patients' safety. They also stated that healthcare organizations are responsible for addressing the communication needs of all of our patients. There's a lot in the literature also that speaks to the importance of communication access in healthcare in particular. This study by Dr. Robin O'Halloran and colleagues found that patients with communication disabilities like aphasia experience barriers that compromise their access to their own healthcare information. And I think this is really powerful to think about because, knowledge is power, right? And so if people have limited access to information and knowledge about their own health and health care, that can be really disempowering, which is not what we want for any of our patients. And other studies have shown that when people experience this kind of decreased communication access, it impacts really important things like their safety, their ability to tell us what they need, and not surprisingly, how satisfied they feel with the care that they're receiving. When there are communication breakdowns, it can also be quite costly. This study by Hertig and colleagues that came out in 2018 was a retrospective 1-year look at acute care hospitals in the US, looking at how many preventable adverse medical events happened for patients who had a communication diagnosis. In 1 year alone, they found almost 700,000 preventable adverse medical events had happened for these patients. And I remember reading this and initially feeling really overwhelmed and discouraged by this finding. And then I realized that there's another way to look at it, which is that there's a great opportunity here that perhaps if we can provide training to more providers and healthcare staff so that they know how to accommodate the communication needs of their patients, look at the impact we could make and how many adverse events and experiences we might be able to prevent. So hopefully I've convinced you that this is important, the why. Now let's talk about the what of communication partner training. I think we can agree it's important that patients have access to their own healthcare information and that their communication needs are met. But many of us as providers don't have access to training on how to do that. So communication partner training, or CPT, is one method of closing that gap. It's defined as a complex behavioral intervention to optimize communication between a person with a communication disability and a range of communication partners. And the citations I have here speak to, when I say communication disability, I'm referring to individuals living with diagnoses like aphasia, Parkinson's disease, dementia, traumatic brain injury, people who use augmentative and alternative communication devices, for example. And CPTs have been implemented with folks with all of those kinds of communication disabilities, as well as a range of communication partners, including close or familiar partners like family and friends, as well as more distant or unfamiliar partners like health professionals and health students, nursing colleagues, chaplains, adaptive transport drivers, and other community members. And the citations cite examples of implementation with those groups. CPT, particularly in rehabilitation settings, is aimed at a number of goals. And I like to think about these on both kind of the micro and macro level. So in terms of micro goals, CPT really aims to empower clinician trainees as communication partners with the knowledge and skills that they need to accommodate the communication needs of their patients. And as they learn how to do this and hopefully communication improves, it can also have positive effects on the person with communication disability to improve their language, communication, participation, and well-being. And I've cited studies listed here, number 2 through 4, speak to some of the negative experiences that people with communication disabilities have that can be reduced if more people understand how to communicate effectively with them, such as reducing their sense of social isolation, mental health difficulties, and secondary care partner burden. So those are some of the micro, kind of more immediate goals. On a broader macro level, communication partner training in rehabilitation settings aims to make communication environments more accessible. When we think about it, if more healthcare staff are trained in how to accommodate patients' communication needs, then that patient is going to be able to access their information more easily, be more empowered, and have more positive care experiences overall. In terms of what the evidence says, there's a lot of it and it is growing. The bottom line is that evidence shows that CPT makes a positive difference. Studies have shown varied positive outcomes with, again, a variety of trainees, as I stated, and it's been shown to be effective when it's delivered both in person as well as online, virtually. And I think this is an important piece when we're thinking about CPT in rehabilitation settings, because for feasibility, it offers a lot more options to be able to deliver it in both those ways effectively. CPT has also been shown to be effective when it involves directly a person with communication disability or through role plays. And this last point here is really critical. The evidence shows that to be effective, CPT should really be tailored to the trainees, the communication partners you're working with, if it's clinical staff, for example, also the context and communication needs that they experience specifically, and that it should include tools and strategies or accommodations that are effective within those contexts and for the patients that you serve. I want to also just note here in terms of the outcomes that in the references, they're mostly studies that are completed in highly resourced English-speaking countries, as well as some Finnish, Danish, and Swedish examples. But I want to highlight 2 references here on this list, the 3rd and 4th one. The 3rd one by Isaacson and colleagues describes partnerships to implement linguistically and culturally adapted CPTs in lower income countries, some of which have primary languages other than English. And the 4th reference by Kong and colleagues is a systematic review that they completed of CPTs with Chinese-speaking people with aphasia. And they have a beautiful example of cultural consideration in terms of outcome measurement within these groups. And they suggest including a mutual communication satisfaction measure that is, quote, compatible with the collectivist value of harmony and solidarity within a group. So I think that's just a really nice concrete example of a cultural consideration that could be implemented when tailoring for those particular groups. Additionally, in the evidence, there are a number of different approaches to CPT that have been documented, and I've listed a number of them here, again, that were implemented with people with different types of communication disabilities. And these are in the reference list too, and I'll just say on the slide, the ones that have an asterisk next to them have free online training available if you want to do a deeper dive into any one of these and you think you might want to implement something similar in your setting. And the ones with camera options involve video recording and playback as part of the education process. And I'll say more about that in a minute. But rather than breaking down each one of these approaches, I thought for today instead, I'd talk about what they have in common. There are three what I see as overlapping key ingredients that all of these approaches include. And I want to talk in a little more detail about each one. And they are, each one includes direct teaching about communication and about communication strategies or accommodations. They all involve some aspect of perspective taking and also contextual considerations for the particular types of communication interactions that they aim to change. So let's take each one of those individually. So the key ingredient of communication, to illustrate an example of this, I'm going to use the model of supported conversation for adults with aphasia by Ora Kagan and colleagues, which comes from the Aphasia Institute of Toronto. So they break down teaching about communication like this. They talk about things a communication partner can do to help get information in or help a person with a communication disability like aphasia understand more easily, things the communication partner can do to help that person get information out or express themselves more easily, and ways to help them ask and answer questions, as well as how the communication partner can verify that they have accurately understood what the person is trying to express to them. So they break communication down in these ways and teach really explicitly about that. And they also teach about higher order aspects of communication that they call transaction and interaction. So they teach about the transaction pieces, ways to exchange information and facts using these kinds of strategies to get information in and out. And they also talk about the interactional aspects, how the communication feels, and they explicitly teach communication partners ways to acknowledge the competence of the person with aphasia, as well as help reveal their competence. So using language that really centers it on the feeling of the communication exchanges. So that's an example of one model, one way, one model explicitly teaches around communication and communication examples. The second key ingredient is perspective taking. So giving the communication partner an opportunity to take on the role of the person with communication disability, put themselves in their shoes and experience some of the struggle. I think this is really critical for developing empathy, to feel motivated as an adult learner to change their behavior to help reduce some of that struggle. And I think in rehabilitation, this is particularly powerful because that's really a big part of what motivates all of us as rehabilitation clinicians. So taking on the role, whether it's reflecting on an experience directly with a person with communication disability or role playing. And then I've also included here aspects of Kolb's theory of experiential learning, where he talks about in order to assimilate new information, we need both concrete experience as well as ways to the abstract conceptual information like an article. So didactic teaching, articles, information to inform the learner's understanding of communication accommodations, and then also experiences, active experimentation, and opportunities to reflect on what they're learning. And this reference by Van Ryssen and colleagues speaks to clinical education scenarios specifically, where clinicians really emphasize the importance and impact of having feedback and coaching in addition to the active experimentation included in their reflection opportunities. And I'll share just a specific example from a communication partner training that we offer in our hospital to all new allied health and nursing employees. We give them an introductory CPT and kind of follow the model of the SCA structure, where they do 2 role plays over the course of the training. One in the beginning before they get any explicit teaching. So we kind of throw them into the deep end, and each person has 1 minute to be in the role of having aphasia and experience struggle when their partner doesn't know how to accommodate their communication needs. And immediately afterward, we have them reflect on how that felt. And so on the left-hand side here, you can see people describing their experience when they were in the role of having aphasia for 1 minute. And they say things, they have powerful feelings like feeling isolated, frustrated, at a loss, underestimated, sad, and worried. And then we do the explicit teaching, the modeling, demonstration, and give them a chance to try it out again in a second role play, where they now have some ways to accommodate their partner's communication needs. And again, we have them reflect immediately afterward on how it felt, and they can really see the difference that they've made. They're feeling seen, understood, respected, hopeful, encouraged, and heard. And so I think this reflection piece, trainees have told us over the years that this is what they sort of think back to when they're then on the floor during clinical care interactions. This is what's motivating to them to try out what they've learned to try to make communication easier for their patients. So perspective taking and reflection is really critical. And then the last key ingredient is this idea of contextual considerations that is a part of all of those different models. And here I'll offer the activity-based communication analysis by Olson and Saldert, which I think gives a really nice framework if you're thinking about implementing CPT in your setting. It helps you think through what content to include in your teaching and role play scenarios, and to really think about which aspects of interactions and transaction to include. So they help you break down the social context by thinking about who are the participants in these interactions. Is it a nurse and the patient, a physical therapist and the patient? You know, is it a nurse trying to give information about a medication or get information about symptoms a patient might be experiencing? Is it a PT who's trying to collect information about a patient's activities and goals and priorities? And to think through how sometimes in those interactions goals may not match between the two, and to give you a chance to teach about that explicitly and help your communication partner learners reflect on those aspects as they learn. They also encourage us to look at factors that can influence communication interactions. And this one, time, I think, is the one that is the biggest in healthcare communication. We all feel pressed for time. So this is something that I consistently teach explicitly about. I address this and say, you may feel like things are moving too quickly and you don't have time to implement these communication strategies with your patient. But actually, if you think about it, if you take the time and use these accommodations and you and your patient understand each other accurately on the front end, it can save you so much time in the future. And I've also lastly included a reference here to an article by Jose Centeno, which talks really beautifully about ways to incorporate the cultural values of our ethno-socially diverse patients and communication partners, which I think are critical considerations when we're developing and implementing communication partner trainings as we consider the patients that we serve. So lastly, the last part of my section here is to offer this example of a communication partner training program that we run here in our hospital called Communication Champions. As Mara said, it's a year-long interdisciplinary communication training program. It is a progressive curriculum that it aims to build the knowledge and skills of each clinician trainee and in the first half of the program, and then support them in the second half to mentor their colleagues and champion what they've learned, sharing it with their teams. This program is offered through our professional development structure or clinical ladders, which is something I would encourage you to think about because it's been really critical for the sustainability of offering this program. It's been running for 7 years now. And it's also offered completely virtually, which has made it available to clinicians across our sites of care. The image that you see on the slide here just represents the curriculum kind of at a bird's eye view. So on the outside of the pyramid, you can see aspects of asynchronous work that the trainees do, including pre-work and reviewing articles relevant to topics that we cover in the meetings that are represented inside the pyramid. And what we do is build kind of a foundation in the beginning. They start out with supported conversation for adults with aphasia. And then in between each meeting, they take what they learn and go back and practice it, implement it with their patients at their sites of care, and do asynchronous reflection, such as keeping logs in between to sort of reflect on their experiences and deepen their learning. We also use those logs when we come back together. Every meeting includes discussion time for the clinician trainees so that we can share ideas, problem solve together, and hear each other's perspectives. So we then progress to advanced SCA concepts, cognitive communication challenges, and then when clinicians transition to the mentorship phase, they do a case study presentation to their colleagues to illustrate how they've been using communication accommodations with their patients and sort of offer themselves as a resource to their teammates to share and help problem solve and use what they were learning in the program for the benefit of their team. And then it comes together at the end by supporting the clinicians to also reflect on the communication environment where they practice. One other piece about the aspect of offering this virtually that I'll mention is that the curriculum involves direct practice also with community member experts with aphasia who can zoom in for conversations with the trainees and offer direct feedback to the learners, which clinicians have said over and over again is such a valuable learning experience. So that is just a very brief overview of the Communication Champions program, which I wanted to offer in case any pieces of this feel like they might be applicable where you practice, and also as context before you hear from Juliana and Lindsay, who both completed this program as clinician trainees. My last piece as a facilitator of this program is that it has been such a privilege every time I've been able to run this. And I've really learned so much from all of the trainees and really value the interdisciplinary learning and collaboration we've been able to do together. So I suggest that for your consideration too. Again, if you're thinking of implementing something similar in your setting, it's just such a valuable and rich learning experience to get to combine our interdisciplinary perspectives as we're growing our communication skills. And with that, we will transition to our panel, and you will now hear from our first panelist, Juliana Valentin.
Thanks, Elissa. I'm so excited to be here today and share my experiences with you all. So like Elissa said, my name is Juliana Valentin, and I've been a practicing physical therapist now for 5 years. I joined the Communication Champions program last year, so that was 4 years into my career. Prior to that, I had received some basic training in supportive communication during my neuro residency year, but without frequent practice, I didn't feel fully confident in using these strategies in real time until I joined the program. I currently work in an intensive outpatient setting called day rehab. Patients here work with PTs, OTs, SLPs, and a variety of ancillary services toward goals that involve returning to work, school, and other valued activities. We get to meet patients at a pivotal point in their rehab journey. Many have just returned home after a stroke and are beginning to both re-engage with their communities and shift their attention back to what matters most to them. I frequently treat patients with varying levels of aphasia and other cognitive communication impairments. As a communication champion, it's truly a privilege to support my patients as they work both toward their physical and their communication recovery. The pin that I wear on my badge serves as a daily reminder of my responsibility that I carry in this role. Given that the setting is so highly interdisciplinary, I do get to work closely with speech therapists to problem solve and brainstorm when there are communication breakdowns with our shared patients. Like Elissa said, I also now get to help mentor colleagues in other disciplines on integrating supportive communication strategies into everyday interactions. Engaging in this formal communication partner training has had a profound impact on my clinical practice in 2 ways. The first is by helping improve how I deliver clear and effective physical therapy education. And the second is it's really helped to strengthen the rapport that I've built with my patients who have communication challenges. Right. All right. So here are some examples to briefly highlight the many ways in which I've been able to incorporate more accessible patient-centered education into my work as a PT. A very common topic post-stroke in physical therapy is high-intensity gait training. I use keywords and drawings such as this one to explain the benefits and ensure that my patients are fully aware of their own target heart rate range so they can better tolerate the progressions that are going to get them there. I've started to also tailor both exertion scales and home exercise programs to be more digestible and relevant to this patient population, which can help increase their motivation and adherence.
For patients at a lower functional level or with cognitive impairments, I've found that simple visual session plans, like the stepwise increase in walking distance, can really help reduce anxiety and improve participation. I've also been able to use drawings like this one to help explain to my patients the rationale for why we're switching between assisted devices within a PT session. Framing these changes in the context of their personal goals, like being able to walk independently without a device, has really helped to increase buy-in. I also regularly share outcome measures using written supports to show progress over time, reinforcing my patients' motivation and confidence. In certain situations, I found that collaborative drawing has worked best. One patient drew this picture here at the bottom to show how his fall happened in his bathroom, which really allowed me to have crucial insight and helped me provide him with more tailored safety recommendations. Lastly, I've also used visuals like this one here on the right side to explain more involved discharge plans. For example, I had a patient who was going to be transitioning to outpatient physical therapy after completing the aphasia program. So this drawing here really helped him understand the timeline moving forward. All right, to wrap up my physical therapy piece, I want to give an example that really illustrates how Communication Champions has deepened my ability to build trust and connection with patients with aphasia. I recently evaluated a woman in her 70s who had expressive aphasia after a stroke. While she had some mild balance and gait impairments, her primary concern and the area that she was most motivated to improve was her speech. At the start, things were a little bit rocky. She questioned the value of physical therapy, and she was not really interested at all in incorporating the treadmill into our sessions. She initially declined any use of pen and paper and became quickly frustrated when she struggled to express herself. Rather than pushing forward past her frustration, I applied some of the techniques I had learned in Communication Champions, and I made it a point to slow down and just work with her to figure out what she was trying to convey. I made sure to validate her goal and connected physical therapy to what mattered most to her. So, what I did is I explained the benefits of high intensity gait training, not only for improving her balance and walking, but also for priming her brain for neuroplasticity to support her upcoming work with speech therapy. This reframing made the therapy feel more relevant and meaningful to her. We also began using pen and paper because it really allowed me to follow her thought process. It allowed us to confirm that I actually understood her correctly and that our conversations were headed in the right direction. Together with her speech therapist, we identified some appropriate speech tasks that I was able to then incorporate into dual task training and physical therapy, and it was all done in a manner that was very supportive. Over time, we were able to do these sessions where she was walking on the treadmill and she was practicing repetition of both walking and speech. And what I really noticed that stood out was the shift in our relationship. She saw that I genuinely wanted to understand what was on her mind, even if it took that extra time that Elissa was saying, or a couple sessions to fine tune our communication. It truly made a big difference. This experience reinforced a key takeaway. Communication strategies might not work right away, but that doesn't mean that they won't work. The key is persistence, creativity, and a willingness to adapt. And this program has really equipped me with that ability to think on my feet, try new approaches, and most importantly, show up as a therapist who listens, cares, and connects. Joining the Communication Champions program has made me not only a more effective clinician, but a more empathetic communicator. And now with that, I'm going to pass it off to Lindsay Escott for her to share her occupational therapy perspective.
Thanks, Juliana. So I'm Lindsay, and I'm an occupational therapist at Shirley Ryan. When I took the Communication Champions course, I had been working for close to 18 years, pretty exclusively in the area of neuro rehab. So I came with some experience in using supportive communication strategies, but I was really excited to learn and practice more through Elissa's course. And from the very first day, the first reading, I learned simple, easy to implement techniques which were new to me and which made an immediate difference in my interactions with patients. So I work in our Think and Speak lab, and my focus is on functional cognition. And most of my patients have had some change to their thinking skills. So this diagram on the left shows our process where I receive a referral from the primary therapy team, and I do a really holistic assessment of people's thinking skills and how they're impacting the person's occupational performance.
So the initial evaluation that I do is really important as it helps us to choose the right intervention approach. And it actually involves a really lengthy, semi-structured type conversation, which we have to modify to align or match with the person's cognitive and communication abilities. And everyone on this call knows that language ability is not always representative of cognitive ability. So the tools and tricks I learned from this course have really helped me to analyze people's cognitive abilities and challenges more accurately and thoroughly when they have trouble with communicating. So this is my little picture. I walk into every session now if I know someone has a communication challenge with a huge stack of blank paper, a Sharpie, and I approach the session differently from the beginning. I'm using words, symbols, gestures, facial expressions to reinforce my message and to clarify their messages. And another huge change for me is I affirm from the very beginning that I know this person is competent and I will be taking the time that we need to understand each other. And that's something I always thought, but I don't think I intentionally communicated that belief to people. So to better illustrate the techniques I use and the impact that they had, I'm going to walk us through a case study. So this gentleman had recurrent left frontal meningioma and suffered a stroke after a resection that he had in that frontal area on the left side. There were movement and functional challenges. He had fluent aphasia and additional cognitive communication breakdowns. He had been in a skilled nursing facility for over 1.5 years, and the goal was for him to move home to live in a newly purchased accessible home with his family. But the team and his family had concerns about his decision-making, his self-monitoring, and just a session or two before I met him, someone had been trying to help him in the shower at our hospital, and he almost slid out of the commode chair. And the situation escalated, and the moment became distressing for everyone. And so now there had been a change to him bathing in bed. So my initial strategy was to request 90 minutes. Elissa was speaking about time at the beginning, instead of my usual 60, so I could have more time for my initial evaluation. And I found him to be an exceptionally motivated communicator. We went through more than a dozen pieces of paper. This is just one. He helped me learn more about him. We established his therapy goals doing the Canadian Occupational Performance Measure. We looked at his orientation. My favorite part of this session was we were having a breakdown, a communication breakdown, and he started using the tattoos on his arm to reinforce a message and to help me understand him better. So we laughed at my poor drawings and we worked together through all those misunderstandings that happened. So when I moved to assess his self-awareness, which can be really challenging, some of those questions can be somewhat abstract when you do an awareness assessment and conversation. This is the pages that we actually use that we developed together while we were talking. We use pictures, symbols, and all of the paper supports that Juliana showed and that I showed, these are happening while we're talking. So it's not something I create ahead of time and then fill in the blanks. So they're meant to kind of supplement the conversation. And by the end of our session, I was confident that he was oriented. I knew more about him as a person. I knew he had very good self-awareness about what was hard for him, what was challenging, what he needed help with. And he established very clearly this goal of showering in his new shower stall at home, instead of being bathed in bed. So he was able to walk me through most of the way through our session. There was some trust, and I said, well, tell me what happened. And he walked me through what happened when he had this near miss in the shower. He was safe and nothing bad happened, but it was a near miss. And he very clearly explained that a small, not inappropriate, but the wrong shower chair had been used, and he should have been using a bigger tilt in space commode chair. And so we decided, after he communicated that so well to me, that we would sit down with his wife and see if we could work through and problem solve how he could shower in his shower stall at home. And I just want to mention that this type of strategy training, when I engage in that with people, they have to have pretty good self-awareness and pretty strong cognitive abilities to discuss things out of context, to imagine, to reflect, and to identify adaptations. And before I took this course, I don't think I would have felt comfortable undertaking this process. And I think I may have missed people in the past who could have done this type of session with me. So in a separate session with his wife present, I facilitated the conversation using the strategies that I knew were helpful. Um, we allowed him to generate ideas and present his perspective to us. So there were a lot of pages, and I'm kind of showing you the summary pages that we agreed upon at the end of each part of this session. So we had him anticipate challenges, and then we had him identify possible solutions. And you can see the titles at the top of these pages are his phrases. So when we said, okay, we're going to think of ideas, he kind of said, I suggest. And so that's what I wrote down. And then we kept going with his suggestions. And then finally, he generated a plan that would help him shower. He called it the easy plan, in this shower stall in his new house with help. And, even on these pages that I'm showing you, which were the good copies, you can see that I've crossed things off, that we made adjustments to make sure that we were verifying that I had things written exactly as he wanted. But he worked his way through all three of these stages. So results of this intervention were that he was a valued member of the conversation. He was empowered, he shared his experience, and he identified solutions that he thought would work. His wife kind of looked at us partway through and just said, this is exactly what he used to do. He was the problem solver. And she said, she had tears in her eyes. It got a little emotional, but she said she didn't even realize he could still fulfill this role in their relationship and in their family. And I think he felt relieved that his opinion was being taken into consideration and proud that we persisted. He communicated his ideas, and we were able to identify how in the future they could use this same kind of template or layout of a conversation with the same pictorial supports to work through problems in the future. So key takeaways for me was that to devote time when I first meet people to establish rapport, find the best way to support their communication. And I try now almost always to ask people if what they're thinking is matching what they're saying. I use the phrase, I know, you know what you're trying to say. And the number of times, like 99% of the time, there's visible relief and like a reduction in tension on people's face and on their energy and even their behavior when I do this. So yeah, just lots of new tools in my own toolbox from this course. So I'm excited to pass you guys on to the best part of this course. I've gotten to know Katie, who's a wonderful human, and she's here to share her lived experience as a stroke survivor and someone who had communication challenges. Over to you, Katie.
Thank you, Lindsay. Hi, my name is Katie Atula, and I'm 33 years old and from a small town in Illinois called Freeport. I attended Western Illinois University and obtained my bachelor's and master's degree. I am a special education teacher at Freeport High School. On April 7, 2023, I had a massive stroke that changed my life forever. My stroke paralyzed my right side, and I could not speak. In the ICU right after my stroke, I could only do thumbs up and thumbs down, and would get that wrong most of the time. I understood everything that was said to me, and when someone would ask me a question, I said the answer in my head. I just couldn't get the words out. After my surgery, the hospital provided me with a communication board pictured on this slide, which I found to be really helpful. A member of my family also got me a mini whiteboard to write on because I couldn't talk. Some things were easier to write down than to use the communication board. I was approved to attend Shirley Ryan Ability Lab for inpatient rehab. I was at Shirley Ryan for 5 weeks. I experienced both good and bad things while in rehab. First, the good. The hospital let me take my communication board with me to Shirley Ryan. That turned out to be a huge help. My therapist, PT, OT, and speech all knew I needed it to communicate, and they all ensured I had it with me. It made me feel like they were listening even though I couldn't talk. One day I had forgotten my communication board and was already in the gym when the physical therapist asked me a question. Realizing I didn't have it with me, she kindly returned to my room to retrieve it. That gesture meant a lot to me, and although I couldn't directly convey my gratitude, I sincerely hope she understands how much it touched me. The speech language pathologist used my communication tools with me, but also took my phone on multiple occasions and recorded videos for me that I could practice on my own because they knew I wanted to get my talking back as much as possible. Next were the doctors. I don't know if they knew I wanted to, sorry. I don't know if they knew, but they didn't just speak down to me or as if I were dumb. They talked to me like a normal adult and not just like I had a stroke. It made me feel good considering I just had a stroke. Now for the bad. When I had to go to the bathroom at night, I would hit the call button and a staff member would come over the speaker in the bed and say, "Can I help you?" I couldn't talk, so they would hang up like I accidentally pressed it, and they never came to my room. So I would press it again until they finally came to my room. When the nurses or other staff would come to my room, they had me use a bedpan without asking me. I am a bigger woman, and the bedpan was uncomfortable and frustrating to use. A couple times I missed the bedpan and ended up getting the sheets wet, which meant they had to change the sheets when they could have just taken me to the bathroom. It made me feel unheard and like they were just trying to get done with me as soon as possible. When no one would come, sometimes I would just pee on myself because I couldn't hold it. It made me feel embarrassed and belittled because I couldn't ask for what I needed. I firmly believe that therapists, doctors, and nurses should receive training to address the communication needs of their patients. As someone who has experienced a stroke with aphasia and faces communication challenges, I can share my perspective. During my time in the hospital and at Shirley Ryan, I felt scared, isolated, and unable to communicate. Truly a person's worst nightmare. The therapists, doctors, and nurses were my primary support in alleviating those feelings of fear and isolation. The support I received from the therapists and doctors was invaluable in helping me feel less alone, and their effectiveness stemmed directly from their specialized training. We must prioritize this education to enhance the care for all patients facing similar struggles. The piece of advice I have for working with people with aphasia communication disabilities is to listen, be patient, and adapt your communication style. Pay close attention to what the person is trying to communicate, both verbally and non-verbally. Give them ample time to process information and formulate their response without interrupting or finishing their sentences for them unless they ask for help. adapt your communication style by keeping it simple, using visual aids, asking focused questions, minimizing distractions, and confirming understanding. Don't assume lack of intelligence. Aphasia, aphasia affects language, not intellect. And I think that needs to be said because the bad is still happening as I experience. Thank you.
Thank you, Katie. And thank you all again for this opportunity. It's been an honor to share with you all today. And we've listed here our contact information if you want to reach out to us at a later time, and also a QR code that links to a document with all of our references that we cited. And I'm gonna just briefly go through them so that they'll be on the recording for people's future reference. People can also reach out directly to ACRM, to the ISIG, if you want a link to reference these. And with that, for now, I'll stop sharing. We'll stop sharing slides and open it up for discussion. We welcome people to unmute and ask questions or put questions in the chat. And I'm seeing already a lovely comment from Maria. Thank you so much for the feedback. We appreciate it.
I'm happy to jump on with a question if that's okay.
That would be great, Amy. Thank you.
So thank you so much to all of you. It really was moving and inspiring. It's clear that the Communication Champions program is cutting edge, right? You're not just showing the impact of supportive communication training on patient outcomes, but also showing how it could be meaningfully implemented across disciplines. In my opinion, as a speech language pathologist, that's sort of like living the dream, and seeing how it's impacted, for instance, you, Katie, it's incredible. And Katie, I just wanted to thank you for sharing your experience and journey and for educating us today. Just sort of wanted to understand better, what do you think clinicians, how clinicians can support someone with communication needs better in their clinical practice, whether they're PT or OT or speech, and how patients could feel empowered to talk to professionals maybe about this?
Well, before early on in my rehab, I could not talk. So I think with the doctors and the therapists, I think they already had either they already had Elissa's training, or they, heard about it. And so I think that was helpful. The nurses, not so much. But I think Elissa's training was, or is going to be great for people to take, and so they know how to communicate with people with disabilities, communication disabilities.
Thank you, Katie, for bravely answering our first question. And thanks for that great question, Amy. And I will just reiterate too that, Communication Champions, the design of it came from what's in the evidence that we know so far about best practices. It continues to evolve. And I think one thing the literature tells us too is that is empowering, in that I think we can all understand how to tailor CPTs for where we work and for the specific context we're trying to change. So I think there's a lot of room for that, for tailoring a training where you are. And you know your settings best. So if you're a rehabilitation practitioner thinking about doing something like this, I really encourage you to give it a try. Keep those key ingredients in mind. Use what you know about your context and the patients you serve, and try it out. One other aspect of the Communication Champions program that's been really valuable is that we always end with sort of a focus group to get feedback from the trainees, and it evolves every year because we keep on learning on how to make it better for people. And so I really encourage that too, to be in partnership with the trainees, can really help the program grow and get further tailored to be more effective over time. I see another question in the chat here. Katie, this I think is directed to you too. The question is if you have any specific suggestions from the perspective of a special education teacher. Should we be more aware of premorbid learning styles as we conduct aphasia rehab? Oh, well, so I want to take a piece of that question because I think part of it is almost like clinical in terms of maybe aphasia therapy. But I wonder, Katie, what you might think about as a special education teacher and expert. Do you think that communication partner training programs should also incorporate ways that clinicians can maybe learn about and adapt to patient learning needs as well?
Yeah, I think so.
Great. I agree. But I love having your endorsement with your expertise. Thank you so much for that question, Jeffrey. Really appreciate it. Any other questions or comments?
What do the rest of you clinicians think about that and communication partners, about the people that learn the motor and sensory and auditory and visual and other ways? What did the rest of you think?
I found a lot of hospitals have the speech therapist they'll provide a package to families to get lots of information in situations where someone can't provide their personal information. So favorite music, favorite hobbies, those kinds of things, favorite foods. To me, a good package that you ask family to fill in would include just what you're speaking to, Jeffrey, sorry. So, because of course, if we draw on people's strengths, right, especially things that were present, our abilities before we now have this new challenge, I completely agree with you that that's often the best way. Sometimes a lot of my therapy involves no words at all. You know what I mean? So I help with functional movement and object use, and people with apraxia, who it often is associated with aphasia. And 100%, we use video. We draw on all the different ways we can input information and facilitate learning. If you need to take words out of it, then yes, for sure, we will look for ways to do that. And families' input or on best learning style that was in place before is really, really, really helpful. It saves us time.
I think I'll just add into that. I love your questions here too, Jeffrey, because I think they get to something that is really at the heart of any communication partner training program, which is see the person in front of you. Don't be intimidated, try to understand what is going on. And if there are communication breakdowns, use every accommodation we can to try to get past those, to get at what is behind it, and really help someone be able to maximally engage. I'm seeing one more question. I know we're almost at time, so this might have to be our last one here. From Monica, are there gender care issues in stroke aphasia rehab resources for female versus male patients? Let's see, for instance, I only see a few male rehab specialists attending today. Any experiences to share, either lived experience or institutional experiences for rehab professionals? Let me think. Are there gender care issues in stroke? So I'm wondering, Monica, if this question is sort of speaking to contextual considerations that we might consider. And I think this is, if I'm understanding your question right, it's a really nuanced point that I appreciate you raising. I think when we're tailoring a training program or when we're empowering trainees to, again, try to optimize the communication, absolutely there may be aspects of sex or gender, or other aspects of intersectional identities that may impact how the communication feels. And so I do think that as much as we can, we want to try to take those into account. And it may involve explicitly addressing something. It may involve talking with the patient to understand what would make them feel most comfortable, and, you know, mobilizing whatever resources we have, whether it's tapping another staff member or member of the family, whatever it may be. Hopefully we can be in partnership with the patient to understand, to optimize in that way too. Thank you so much for raising that contextual consideration point. What an amazing question to end on, and what a thoughtful audience. Thank you all again for the time today. Thanks so much to Amy and Mara for everything you've done to make this so smooth as a process to present today. This has been a great opportunity overall. I'm going to bring back up some slides here because I know Amy has a couple of final points to share before we close today. So just one moment.
Thank you so much. So I'm sure everyone will join me in thanking the speakers for this wonderful, informative presentation. I still have so many questions and I learned so much during this. And thanks to everyone who attended this webinar. We also wanted to take the time to express our gratitude to our moderator, Elissa Larkin, for organizing this presentation. We're truly appreciative for the time and expertise you share with us, and you all shared with us at the ACRM/ISIG. And Mara had mentioned this at the beginning, but there will be a recording of this presentation and it'll be posted in a few days, and you'll be able to access it using the same link you used to access this webinar. So no password or registration is going to be needed for that. And feel free to share it with any colleagues who weren't able to attend today. I know some people already said in the chat they're hoping to share it with their teams. I'm certainly going to be sharing it with mine. We also want to let you know that ACRM's annual conference is coming up and will be hosted in Chicago on October 27th through 30th. So we hope to see you there. Mara and I will be there. Be on the lookout for social media postings from the ACRM/ISIG and the Aphasia and Other Communication Disorders Task Force. We'll be highlighting some upcoming presentations that are of interest to our task force. And again, just thank you for your attention, for your time, and thanks to all our presenters today for doing such an incredible job in educating us.
Thank you all again for the opportunity. It's been a wonderful experience, and we wish you all the best as hopefully folks are inspired to implement communication partner trainings where you are. And again, our contact information is there too. So if you do have follow-up questions, we're all more than happy to respond. Thank you for the lovely comments in the chat. We so appreciate it.